Okay, students, this time we're going to talk about some conditions that you will see with erythrocyte disorders that nurses need to pay special attention to and care for. Um, so let's just begin here. Caring for erythrocyte disorders is important for oxygenation and tissue perfusion because the blood itself is one of the oxygen delivery systems. All systems depend on blood or oxygen perfusion. Any problems with the hematologic system affects the total body health and the well-being. So first we're going to start talking about some anemias. Anemia is the most common hematologic disorder in infancy and children and is not a disease itself, but an indication of manifestations of an underlying pathological process. Anemia is classified in relation to etiology, in other words, your manifestation of depletion, and morphology, your characteristics, size, and the shape, and the color of your red blood cells. Okay? The etiology approach provides direction for changing nursing care. The effects of anemia on the circulatory system can be profound. Growth retardation can resulting from decreased cellular metabolism and coexisting anorexia is a common finding in chronic severe anemia and is frequently accompanied by delayed sexual maturation in your older child. And we will be talking about adults and children both during this lecture. The objectives for medical management is to reverse the anemia by treating the underlying cause and to make up for any deficiency in blood components, or substances that blood needs for normal functioning. In patients with severe anemia, supportive medical care may include oxygen therapy, bed rest, and replacement of intravenous volume with IV fluids. The prognosis of anemia depends on the correction of the cause. Iron deficiency anemia occurs more frequently in toddlers between 12 and 36 weeks of age and during the growth spurts of adolescence. Racial and ethical background is significant. The anemias related to abnormal hemoglobin levels are found in Southeast Asians and people of African and Mediterranean ancestry. Special emphasis is placed on a careful history to elicit any information that might help identify the cause of the anemia. The nurse is responsible for preparing the patient and the family for tests by explaining the significance of each test, particularly why the tests are not all done at one time. Encourage your parents or family or other supportive people to be with a child, especially during the procedure, and allow any child to play with the equipment on a doll or participate in the actual procedure. Bone marrow aspiration is not routine hematologic test, but is essential for definitive diagnosis of leukemias, lymphomas, and certain anemias. Because the pathology process in anemia is a decrease in the oxygen carrying capacity, an important nursing responsibility is to assess the patient's energy level and minimize excessive demands. Signs of exertion include your tachycardias, your palpitations, tachypnea, dyspnea, shortness of breath, hyperpnea, breathlessness, dizziness, lightheadedness, diaphoresis, and changes in the skin color. The patient looks fatigued. They might be sagging. Children, you can see them with a limp posture. They'll be slow. They'll have strained movements, inability to tolerate any additional activities, And the infants, you will see them having difficulty with their sucking. Patients who are so severely anemic that they are hospitalized may require oxygen to prevent or reduce tissue hypoxia. These children can be susceptible to infections, and every effort is expanded to prevent or reduce tissue hypoxia in the child. You also want to prevent any exposure to infective agents in these children. All of the usual precautions are taken to prevent an infection, such as practicing your thorough hand washing, selecting an appropriate room with in a non-infectious area, restricting visitors or hospital personnel with active infections, maintaining your adequate nutrition. You also need to observe for signs of infection, particularly temperature elevations and leukocytosis. Okay, like I said, common manifestations are their pallor, especially in the ears, the nail beds, the palmar creases, conjunctiva, and around the mouth. They're going to be cool to touch. They're going to have intolerance of cold. They're going to have the tachycardia, like I mentioned, murmurs and gallops with severe anemia and orthostatic hypotension. They're going to have dyspnea on exertion, fatigue, and some complaint of headaches. Categories for anemia. Anemia can be caused by blood loss, impaired red blood cell production, increased destruction of the red blood cells, nutritional deficiencies, which come in two classes, the etiology and the morphology. Anemia secondary to blood loss. You can have an acute blood loss, which is sudden direct result of a decrease in the number of circulating red blood cells, or you can have a chronic blood loss, which is gradual loss of the circulating red blood cells. I have made charts for you here that should help you with your studying for acute loss. Your etiology is hemorrhage, tumor, GI bleed. Signs and symptoms, you're going to look for signs of shock like restlessness. They're going to be cool, moist skin, pallor, increased pulse, decreased blood pressure. Your medical management, you're going to stop that source of bleeding, of course. You want to restore any losses with IV fluids or maybe even transfusions, treat shock, oxygen as needed. Your nursing management, you're going to be responsible for monitoring vital signs, going to have them on bed rest with their legs elevated, monitor transfusions and IVs, and you're going to administer medications as ordered. For chronic blood loss, your etiology is going to be a slow GI loss or vaginal bleeding like in menstrual disorders or hemorrhoids. Signs and symptoms, they can be asymptomatic with red blood cells and hemoglobin at a depressed level, especially if this is a very chronic, slow bleed. They can have chronic fatigue, weakness, elevated pulses, exertional dyspnea, and pallor. Management is you're going to stop that source of blood loss, you're going to promote their nutrition, and give them iron supplements. Anemia secondary to impaired red blood cell production is going to be your aplastic anemia, which is pancytopenia, or depression or cessation of all blood-forming elements, which is pancytopenia. Aplastic anemia. On the aplastic anemia, you will see the etiology is bone marrow depression, drugs, chemicals, viruses, radiation, and of course on the chemicals it's like your chemotherapy agents, or stem cell failure from mature or unknown causes like your autoimmune diseases. Aplastic anemia is also referred to as AA. The peripheral blood smear demonstrates pancytopenia or a triad of profound anemia, leukopenia, and thrombocytopenia. Hypoplastic anemia is characterized as a profound depression of the red blood cells, but normal or slightly decreased white blood cell counts and platelets. Your aplastic anemia can be primary, which is congenital, or secondary and acquired. The best known congenital disorder of which aplastic anemia is an outstanding feature is your Fanconi's syndrome. It is a rare hereditary disorder characterized by pancytopenia, hypoplasia of the bone marrow, and a patchy brown discoloration of the skin resulting from deposits of melanin, and associated with multiple congenital anomalies of the musculoskeletal and the genitourinary system. The syndrome appears to be inherited as an autosomal recessive trait. It affects siblings. Affected siblings may demonstrate several different combinations of defects. Acquired aplastic anemia is classified as either severe acquired aplastic anemia or moderate acquired aplastic anemia. Severe carries a poorer prognosis and follows a more rapidly fatal course than the primary type. The onset of clinical manifestations include anemia, leukopenia, and decreased platelet counts, and they are usually insidious. Definitive diagnosis is determined by bone marrow examination, which demonstrates the conversion of red bone marrow to yellow or fatty bone marrow. In severe aplastic anemia is defined as less than 25% of bone marrow cellularity with at least two of the following findings: absolute granulocyte count of less than 500, a platelet count of less than 20,000, or an absolute reticulocyte count of less than 40,000. Moderate aplastic anemia is defined as more than 25% of bone marrow cellularity with the presence of mild to moderate cytopenia. The objective of treatments are based on the recognition of the underlying disease process is a failure of the bone marrow to carry out the hemopoietic function. Therapy is directed at restoring the function of the marrow and involves two main approaches: either immunosuppressive therapy to remove the presumed immunologic function that prolonged aplasia, or replacement of the bone marrow through transplantation. Bone marrow transplantation is the treatment of choice for severe aplastic anemia when a suitable donor exists. ALG or ATG are the principal drug treatments for use in aplastic anemia. ATG is cyclosporin suppressive T-cell dependent autoimmune responses but do not cause bone marrow suppression. The cyclosporin is administered orally for several weeks to months, and the ATG usually is administered intravenously over 12 to 16 hours for 4 days after a test dose to check for hypersensitivity. Because of the hypersensitivity response associated with ATG, like fever, chills, myalgia, methylprednisolone is given intravenously to prevent these side effects. Androgens may be used with ATGs to stimulate erythropoiesis if the aplastic anemia is unresponsive to initial therapies. Hemopoiesis stem cell transplantation can be considered early in the course of the disease if a compatible donor is found. Transfusions have synthesized the child to leukocytes and human leukocyte antigen HLA. The care of a child or a person with aplastic anemia is similar to that of a person with leukemia and involves preparing the patient and the family for diagnostic and therapeutic procedures, preventing complications from severe pancytopenia, and emotionally supporting them in the face of a potentially fatal outcome. The drug ATG is usually administered by way of the central vein. If not, vigilant care must be directed at the IV infusion to prevent exacerbation. Meticulous care of the venous access is essential because the patient is susceptible to infections. Homeostasis is the process that stops the bleeding from blood vessels when a blood vessel is injured. Vascular and plasma clotting factors as well as platelets are required. Like your chart says, you want to remove the causative agent if possible on this and get that definitive diagnosis. Okay, your symptoms are going to be the same as with blood loss and infection and bleeding. Immunosuppressive therapy, like I was telling you, the ALG and the ATG suppresses the T cell dependent and the autoimmune response. It does not cause the bone marrow suppression. It's colony stimulating factor is given sub-Q to enhance the bone marrow production, and your cyclosporin and your methylprednisolone is given. Your patient teaching for your aplastic anemia is you want to teach them about infections, prevention. Good hand washing, avoid contact with those who have infections, do good hygiene, eliminate their intake of raw meats or fruits and vegetables because they could carry bacteria and parasites. You want to report any signs and symptoms of infection immediately. You want to teach them to observe for any bleeding such as bloody urine, stool, or petechia. They will need to use a soft toothbrush or swabs to brush their teeth. They need to avoid enemas or any rectal insertions. Avoid picking or blowing their nose forcefully. You would want to instruct them to blow their nose actually with their mouth open to help decrease the pressure. They need to avoid any trauma, avoid using aspirins, and use electric razor. Anemia is related to increased destruction of the red blood cell. Can be your congenital ones, such as your sickle cell disease, your thalassemia major and minor, and enzyme deficiency G6PD. Your acquired can be warm antibodies or cold antibodies. Let's just take a deep breath here. I know this is a lot of material, so just take a deep breath and relax before we move on. Now let's go on to the congenital, which is your sickle cell disease or sickle cell anemia. Sickle cell anemia is one of a group of diseases collectively termed as hemoglobinopathies, in which normal adult hemoglobin is partial or completely replaced with an abnormal sickled hemoglobin. Sickle cell anemia is a homozygous form of the disease. Sickle cell anemia is most common in African Americans, followed by sickle cell C disease and sickle thalassemia. Sickle cell disease is one of the most common genetic diseases worldwide. It affects approximately 90,000 Americans, primarily African Americans, followed by Hispanics, with a lower incidence in other ethnic groups. The gene that determines the production of hemoglobin S is situated in the autosome and, when present, is always detectable and therefore dominant. Heterozygote persons who have both abnormal hemoglobin A and abnormal hemoglobin S are said to have sickle cell trait. When both parents have sickle cell trait, there's a 25% chance with each pregnancy of producing an offspring with sickle cell anemia. The most common genetic disorder in the United States, it occurs primarily in blacks. 1 in 12 are carriers of the trait, and 1 in 375 have the sickle cell anemia. The normal lifespan of the hemoglobin is reduced when it is hemoglobin S. The normal lifespan on hemoglobin A is 120 days. The lifespan for one that has a hemoglobin S is reduced to 15 to 20 days. You can see that is a dramatic drop. Let's see what you know about sickle cell anemia. Sickle cell is a disease that affects only blacks. These are all true or false. Sickle cell is a hereditary disease, and normal blood cells flow through the circulating system more easily than sickled cells. Sickle cells have a life expectancy of 15 to 20 days. The first signs of sickle cell trait typically appear during early childhood. The symptoms of sickle cell are caused by tissue hypoxia, leg ulcers, joint pain, jaundice, and susceptibility infections are all signs and symptoms of sickle cell anemia. The incidence of emotional problems among sickle cell patients is much higher than the general population. Sickle cell anemia patients generally cannot continue with work or school. Increased fluid intake and IV fluids are important to the sickle cell patient. So I hope you got those all right. Let's go on exploring our sickle cell anemia to see if you've gotten your answers correct. Like I said, sickle cell S circulates quite normally until stressed by dehydration, infection, fever, cold, exposure to hypoxia, strenuous exercises, climbing in high altitudes, anesthesia, or extreme fatigue. In other words, any event that increases the body's need for oxygen or that alters the transportation of oxygen can lead to a sickle cell crisis. Clinical features of sickle cell anemia are primarily the result of obstruction caused by the sickled red blood cells, vascular inflammation, and increased red blood cell destruction. The abnormal adhesion, entanglement, and enmeshment of rigid sickle-shaped cells accompanied by inflammatory process intermittently block the microcirculation, causing vasoocclusion. Most of the complications seen in sickle cell anemia can be traced to this process and its impact on various organs in the body. Okay, during times of physiological and emotional stress, the red blood cells form into the sickle shape and jam up the small capillaries of the body. Usually sickle cells resume a normal shape when the precipitating condition is removed. However, some of the hemoglobin may remain twisted. The frequency and severity of the crisis can vary widely. What to diagnose prior? You want to diagnose it prior to 3 to 6 months, but usually it's not. Do you know why this is so? With supportive care, they can live into their 30s or 40s. The most acute symptoms of the disease occur during periods of exacerbation called crises. The crisis can occur individual or concomitantly with one or more other crises. A vaso-occlusive crisis, or a VOC, is characterized by ischemic causing mild to severe pain that may last from minutes to days. Sequestration crisis is a pulling of a large amount of blood, usually in the spleen, infrequently in the liver, and it causes a decreased blood flow and ultimately shock. Aplastic crisis is diminished red blood cell protection, usually caused by viral infections that can result in a profound anemia. Hyperhemolytic crisis is an accelerated rate of red blood cell destruction characterized by anemia, jaundice, and reticulocytosis. Another serious complication that they can come into is the acute chest syndrome, and we will discuss that a little later on. Let's see, sickle cell anemia versus sickle cell trait. Sickle cell anemia is an autosomal recessive genetic disorder. The patient must inherit 2 abnormal genes, and if the patient has children, each child will inherit 1 of the 2 abnormal genes and at least have sickle cell trait. Sickle cell trait, the patient inherits 1 abnormal gene and 1 normal gene, and they only have mild manifestations of the disease under severe precipitating conditions, because less than 30% of that patient's hemoglobin is a hemoglobin S. Okay? Acute episodes, you will see pain, especially back, chest, and their extremities. They'll have low-grade fever. They'll have vaso-occlusion crisis, the sequestration crisis, and the hemolytic crisis. In chronic episodes, you're going to see things like leg ulcers, renal problems, ocular problems, pulmonary problems, chest syndrome, and cardiac problems. Tissue and organs most commonly affected are the spleen, the liver, the heart, the kidneys, the brain, the bones, and the retina. Medical management, you're going to have pain management, fluid replacement to help carry the cells through the occluded passages, oxygen therapy to prevent sickling, folic acid supplementation to promote red blood cell production. They may have to have transfusions, especially if there's an aplastic crisis that occurs, and medications like hydroxyurea and erythropoietin. The hydroxyurea is an oral anti-neoplastic drug. It's used to treat the leukemia and other neoplasms. It has been found to increase the production of fetal hemoglobin, which has increased oxygen-carrying affinity, and it inhibits the polymerization of sickle cell hemoglobin. It will be started out at 15 milligrams per kilogram daily, increasing at 5 milligrams per kilogram per day every 8 to 12 weeks until a maximum of 30 to 35 milligrams per kilogram daily is reached, or bone marrow suppression occurs. Your nursing management, you are going to ensure that they have adequate hydration. IV fluids, encourage drinking lots of warm fluids. You're going to do I&Os. You want them to stay away from caffeine and alcohol, and you do not want to apply ice packs. You're going to maintain the tissue oxygenation, bed rest, supplement oxygen, and keep the room warm. You're going to prevent infections, provide comfort. You're going to assess for pain, provide analgesics. A lot of these patients will have pain pumps. Remove their restrictive clothing. You want nice, loose clothing. Promote psychological comfort. You want to provide them with a quiet, restful environment and provide them with lots of patient teaching. You want to make sure that there is a reduction in the negative connotation that's associated with the term crisis. It's best to say that they're having a pain episode. Crisis can be a very scary word for quite a few patients. If blood transfusions or exchange transfusions are given, the nurse you're going to be responsible for observing for signs of transfusion reactions. Hypovolemia from too rapid a transfusion can cause a workload on the heart, so you need to be alert for signs and symptoms of cardiac failure. In splenic sequestration, the size of the spleen is gently measured by abdominal palpation. This needs to be done very carefully because your fingernails can actually tear the spleen. The nurse should be aware that the spleen size, because increasing splenomegaly is an ominous sign. Anemia is typically not a presenting complication of your VOC, but it is a critical problem in other types of crises. Oxygen is not beneficial in your vaso-occlusive episodes unless hypoxemia is present. It does not reverse the sickled red blood cells, and if used in a non-hypoxic patient, it can decrease the erythropoietin that the body produces. Prolonged use of oxygen can aggravate the anemia. Signs and lack of therapeutic benefit that you need to watch for are restlessness, increased pallor, continued pain. Diuretics can result in electrolyte loss. You need to observe for any signs of hypokalemia, and you need to be familiar with normal serum electrolyte values and report these changes. You also need to be aware of signs of acute chest syndrome and CVA, both potentially fatal complications. Heat is applied to affected areas can be soothing. Cold compresses are not applied because they enhance the sickling and vasoconstriction that your patient will be experiencing. Bed rest is usually well tolerated during a crisis, although actual rest depends greatly on the pain alleviation and organized schedules that the nursing department gives. Some activities, particularly passive range of motion exercises, is beneficial to promote circulation. Usually the best course of action is to let the child or the patient dictate their activity tolerance. Families need the opportunity to discuss their feelings regarding the transmitting of potentially fatal chronic illness to their child. 3 manifestations of sickle cell disease that may appear in the first 2 years of life are sausage-like digits, which is dysolitis, severe anemia, and leukocytosis, and they can be predictors of the disease severity. If family members have sickle cell disease trait or sickle cell anemia, genetic counseling is necessary. A primary consideration in genetic counseling is to inform the parents of a 25% chance that each pregnancy of having a child with the disease when both parents carry the trait. The laboratory findings, you will find a large percentage of the hemoglobin S present. Less than 40% will indicate a sickle cell trait. Greater than 40% will indicate sickle cell disease. They will have a positive sickling test, which is called SickleDex. They'll have a low hemoglobin and hematocrit during their crisis. Reticulocyte counts will elevate, and they'll have an increased white blood cell count. What do you think? Are nurses adequately prepared to care for the pain that these patients experience in sickle cell? Prevention. Most instrumental has been the development of newborn screening programs to enhance early detection, treatment, and prevention of complications associated with sickle cell anemia. What level of prevention do you think this would be? Primary, secondary, tertiary? Studies revealing a cure for sickle cell disease. In a study, 22 patients under the age of 16 who had symptomatic sickle cell disease received marrow grafts from a HLA identical sibling. After a median follow-up of 2 years, 2 of those patients had died, but 16 of the 20 who were alive had no symptoms of sickle cell disease. The 4 remaining patients rejected the graft and their symptoms did return. Now let's talk about thalassemia. Thalassemia major and thalassemia minor. Thalassemia is an autosomal recessive genetic disorder affecting primarily the Italians, Greeks, Chinese, Southeast Asians, and blacks, ethnic groups whose origins are near the Mediterranean Sea. It's characterized by a decreased synthesis of one of the globulin chains in the hemoglobin, resulting in decreased red blood cell production and a chronic hemolytic anemia. Thalassemia minor is called thalassemia trait. It's heterozygotes. It usually is asymptomatic or has symptoms of a mild anemia, and there's no therapy that's usually needed. Now, your thalassemia major is called Cooley's anemia, and it is homozygous. Usually is severe anemia. They have a large spleen and liver, jaundice, greenish-brown complexion. They have growth failure. They have fragile bones and cardiac failure. Okay? The term thalassemia is applied to a variety of inherited blood disorders. Normal postnatal hemoglobin is composed of 2 alpha and 2 beta polypeptide chains. In B thalassemia, there is a partial or complete deficiency of the synthesis of the B chain on the hemoglobin molecule, which results in defective hemoglobin formation. It is very unstable and it disintegrates. It damages the red blood cell and causes that severe anemia. Excessive iron from hemolysis of the supplemental red blood cells in transfusion and from rapid destruction of defective cells is stored in various organs. The onset of thalassemia major may be insidious and not recognized until the latter half of infancy. The clinical effects of thalassemia major are primarily attributed to defective synthesis of hemoglobin A, structurally impaired red blood cells, and shortened lifespan of the erythrocytes. Low hemoglobin and hematocrit levels are seen in severe anemia, although they are typically lower than the reduction of red blood cell count because of the proliferation of immature erythrocytes. The objective of supportive therapy are to maintain sufficient hemoglobin levels and prevent bone marrow expansion and the resulting bone deformities, and to provide sufficient red blood cells to support normal growth and normal physical activity. Transfusions are the foundation to medical management with the goal of maintaining the hemoglobin level of 9.5 grams per deciliter, an aim that may require transfusions as often as every 3 to 5 weeks. The advantage of this therapy includes improvement of physical and physiologic well-being because of the ability to participate in normal activity, decreased cardiomyopathy, and hepatosplenomegaly, fewer bone changes, normal to near normal growth and development until puberty, and fewer infections. A potential complication of frequent blood transfusions is iron overload because the body has no effective means of eliminating the excessive iron. The mineral is deposited in body tissue. To minimize the development of hemosiderosis, the oral iron chelator of deferricerox has been shown to be a safe equivalent for deferoxamine, which is a parenteral iron chelating agent. and it's more tolerable to the parents and the family. In some children with severe splenomegaly who require repeated transfusions, a splenectomy may be necessary to decrease the disabling effects of abdominal pressure and to increase the lifespan of supplemental red blood cells. A major post-splenectomy complication is severe and overwhelming infection. Ensure that the family and the patient understand the need to notify a health professional for all fevers of 101.3 degrees Fahrenheit or greater, because the risk of sepsis in a child with asplenia. Most children are treated with blood transfusions, and early chitillation therapy survives well into adulthood. Most common cause of death for these patients is heart disease, post-splenectomy, sepsis, and multiple organ failure secondary to your hemochromatosis. The objective of nursing care are to promote compliance with transfusions and chitillation therapy, assist the child in coping with the anxiety-provoking treatment and the effects of the illness, foster the child and the family's adjustment to the chronic illness, and observe for complications of multiple blood transfusions. All families with children with thalassemia must be tested for traits and referred to genetic counseling. Like it says, excuse me, enzyme deficiency G6 PD is glucose 6-phosphate dehydrogenase. Patients inherit a shortage of the enzyme that helps protect the red blood cells against breakdown. This makes the red blood cells more susceptible to damage in early breakdown. Bacteria and viral infections are the most common triggers and oxidation drugs. G6PD signs and symptoms are the symptoms of anemia, decreased hematocrit, fatigue, increased serum bilirubin, and dark urine. Episodes are usually short-lived, lasting only until the older red blood cells are destroyed. Your medical management is recognition of the disorder and stopping the offending drug or infection. During the period of acute hemolysis, the patient will require rest, hydration, and assessment of kidney function. Acquired immunohemolytic anemia. Something causes antibodies to form against normal red blood cells. The most often are drug-induced and caused by an autoimmune disorder. Immune hemolytic anemias may be classified as warm or cold, reflecting the temperature in which the patient's antibodies are more active. Acquired hemolytic warm antibodies. Your etiology is active. It actively destroys red blood cells at 98.6 degrees Fahrenheit. It may develop if the patient has lymphocytic cancer or autoimmune IgG. Drugs that can trigger this are penicillin, cephalosporins, methylodopa, and quinine. Signs and symptoms are sudden onset of moderate to severe anemia, splenomegaly, hyperbilirubinemia, hemoglobinemia, and hemoglobinuria, and shock. Complications that you will see with this are DVTs. Medical management is you're going to remove the provoking drug, corticosteroids to suppress your autoimmune reactions. Why is a transfusion made difficult? Because the body would also attack those cells. Splenectomy may be done if corticosteroids are not effective. What are your nursing considerations for splenectomy in this? Okay, your acquired hemolytic cold antibodies. The etiology is most destructive at subnormal temperatures like 86 degrees Fahrenheit. Decreases that trigger this type of reaction include mono, your pneumonias, cancer, and lymphatic system, and your autoimmune, IgM. Signs and symptoms include slowly worsening anemia, pallor, ischemia, skin breakdown in the extremities called Raynaud's-like responses, and the greatest red blood cell breakdown occurs in parts of the body that are exposed to cold, like your hands, your face, your arms, your neck. Medical management: keep that patient warm. They'll also be given steroid therapy, plasma exchange therapy, splenectomy, and more intensive immunosuppressive therapy may be required. What are your nursing considerations for this patient? Last category of anemia, secondary to nutritional deficiency. Examples are your iron deficiency anemia, which is the most prevalent nutritional disorder in the United States, and then you have megaloblastic anemia, or your vitamin B12 deficiency, or pernicious anemia, folic acid deficiency. Okay, your iron deficiency anemia is caused by any number of factors that decrease the supply of iron, impair its absorption, or increase the body's need for iron, or affect the synthesis of hemoglobin. Iron stores are usually adequate for the first 5 to 6 months in a full-term infant, but for only 2 to 3 months in a preterm infant. And this is a differentiation that you need to know. And also in multiple births. Physiologic anemia should not be confused with iron deficiency anemia resulting from natural causes, or nutritional causes, excuse me. Iron deficiency anemia is a functional part of the hemoglobin molecule. Iron is a functional part of the hemoglobin molecule. It is a chronic, microcytic, small, hypochromatic, pale anemia. All right? You have 4 major risk groups. Let's see if you can name those. Okay? Iron deficiency anemia. The etiology is deficiency of iron leads to synthesis of red blood cells with a decreased amount of hemoglobin. Eventually, it leads to a decreased number of cells. Your signs and symptoms are fewer overt clinical signs and symptoms in the early stages. Then they gradually develop into fatigue, exertional dyspnea, numbness and tingling in the limbs, pica. The tongue has a smooth, shiny, bright red appearance, cracks in the corners of the mouth, brittle, spoon-shaped nails with longitudinal ridges on those nails. What would you expect to see in the lab report of a patient with iron deficiency anemia? Management of iron deficiency anemia would be to determine the cause and correct it, provide adequate balanced diet, administer ferrous sulfate orally, 0.2 grams orally TID for about 6 months, or parenterally dexatran or Amaron if the GI absorption is insufficient. Insufficient. Nursing considerations with iron administration: you want to take it 1 hour after meals. If they have GI upset, they can take it with meals, but not dairy products, eggs, coffee, or tea, because they will bind with the iron. You want to take it with a glass of water or a glass of juice, orange juice preferably. Liquid preparations are taken through a straw because it can permanently stain the teeth. Teaching that stool, you need to teach them that their stools may be black and they should report any symptoms of diarrhea, nausea, vomiting, severe stomach pain, or fever to their physician. Teach them about foods that are high in iron. Do not be surprised if you don't see some questions on your test about the different food groups and foods that would benefit on iron. Do not double up on any missed doses of any iron medications. IM injections of iron, there are some special considerations. They are painful and they should be given only in a deep gluteus maximus with about a 2-inch needle. Change to a fresh needle after you draw the iron up. You want to use a Z-track method to prevent any tattooing of the skin. That tattooing can last 6 months or might even possibly be permanent. You want to inject it very slowly. You do not want to massage where the injection was, and you want to assess their level of knowledge of getting their injections at home, especially if you have a patient that has pernicious anemia. They will be on injections for the rest of their life, and you need to make sure that you assess that someone is able to give it to them, or that they have a health nurse coming in to do that for them. Now let's talk about megaloblastic anemia. Involved defective DNA synthesis and abnormal red blood cell maturation. Microscopic examination shows oversized red blood cells called megaloblast. They're easily destroyed because they have a fragile membrane. Most megaloblastic anemias are caused by deficiency in either B12 or folic acid. Both are essential for the synthesis of DNA. And I said these patients will have pernicious anemia. Who are the people at risk for megaloblastic anemia? I've given you quite a few of these that I have not given you the answers for. I think that this would help you some with your studying. If you look up and fill in the answers on each one of these slides yourself, that might help you with your synthesis of the information that you're receiving. Vitamin B12 deficiency. The etiology is dietary deficiency. Surgical removal of stomach. Malabsorption syndromes like your pernicious anemia can be caused by the absence of intrinsic factors which allow vitamin B12 to be absorbed. Signs and symptoms. General symptoms related to anemia. Your skin manifestations like your purpura, your petechiae, your jaundice. You're going to have GI manifestations like a sore tongue, nausea, vomiting, abdominal pain, anorexia. Your neurological abnormalities can also develop. Treatment will be oral or parenteral administration of vitamin B12 until deficiency is corrected. Your patients with pernicious anemia will require vitamin B12 injections for life, as I stated earlier. The best dietary sources of vitamin B12 are liver, organ meats. Other sources are your egg yolks, your dietary produce, your dairy produce, chicken and shellfish. Diagnostic testing will be the Schilling's test, and you can read about this in your lab book. Now, folic acid deficiency is the most widespread vitamin disorder on the face of the earth. It can be due to dietary deficiency. It's often associated with chronic alcoholism, anorexia, overcooking of vegetables, and malabsorption syndrome. Absence of neurological involvement helps you to differentiate between folic acid deficiency and vitamin B12 deficiency. Okay, the etiology is the red blood cells fail to mature and become larger than normal. It can cause the white blood cells and the platelet counts to drop. Folic acid is essential for the synthesis of red blood cells. Signs and symptoms are associated with the underlying disease and anemia in general. Treatment is oral folic acid or 15 milligrams IM or IV, followed by 5 milligrams a day for 1 week. And a well-balanced diet of liver, yeast, green leafy vegetables. All of these are high in folic acid. Now let's move on, excuse me, to polycythemia vera. You can have polycythemia vera primary or polycythemia vera secondary. All right? It's related to congenital disease. It's a chromosomal mutation in a single stem cell, resulting in increased red blood cells, platelets, and white blood cells. A secondary would be an increase in red blood cells that can be physiological move to higher altitude can cause this. After increased physical training, increase in response to need or an increased oxygen, your white blood cells and your platelet cells will be normal. Etiology of polycythemia vera is unknown. Without treatment, the life expectancy is 2 years. Signs and symptoms will be hypervolemia. You're going to have an increase in blood viscosity from increased in red blood cell mass. They're going to have headaches, vertigo, tinnitus, blurred vision, thrombosis, and embolization may occur. The skin is going to be red in appearance. Their platelets are going to be dysfunctional. Splenomegaly and hepatomegaly will be seen, and you'll have porosis. Treatment is periodic phlebotomy. It's aimed at maintaining the hemoglobin and hematocrit at a normal level. At the time of diagnosis, 300 to 500 milliliters of blood may be removed every other day for about 3 to 4 months. Every other day, and then about every 3 to 4 months after that. In severe cases, myelosuppressive therapy may help with, or chemotherapeutic agents may be used. Secondary, they're going to they're going to treat the cause. Key is prevention of thrombosis formation. You need to make sure they have adequate hydration. Anticoagulants may be used. Elevate their feet and encourage them to use support hose. That is the end of this session. Make a note to yourself to just take a breath and relax. I know this is an extremely large amount. Please, if you feel the need, go back through some of these sections. If it's unclear, you can feel free to call me and text me, send me an email through Blackboard, and I will get back to you as soon as I possibly can. I at least check mine every day, if not more often. Now let's go to platelet disorders. Platelets are cell fragments formed in the bone marrow that serve as the body's first barrier to blood loss through vessel injury. They have the ability to aggregate and adhere at the site of vessel injury, thus plugging the small leaks. Platelets release thromboplastin as a first step in the coagulation process. Their normal lifespan is only 10 days. Platelet production is suppressed by most of the same drugs and chemicals that suppress the red blood cell production. Aspirin is a primary drug known to have active antiplatelet activity, but there are over 70 other drugs that have been shown to induce thrombocytopenia. Clinical manifestations and medical management of idiopathic thrombocytopenia. You will notice that the clinical manifestations, easy bruising, you'll have petechia, ecchymosis, most commonly over bony prominences, hematomas over lower extremities, prolonged bleeding from adhesions, acronosis, bleeding from mucous membranes. You have epistaxis, bleeding gums, internal hemorrhages evidenced by hematuria, hematemesis, melena, hemarthrosis, or menorrhagia. Intracranial bleeding is your most serious complication. Medical management is corticosteroid therapy. 80% is effective. You have splenectomy as the last resort, platelet transfusion or plasmapheresis, IVIG, which is intravenous immune globulins, and anti-D antibody therapy. You need to see the box for criteria on the anti-D antibody therapy in your nursing alert in your PEDS book. After administration of any anti-D antibodies, observe the child for a minimum of 1 hour and maintain the patient's IV. Obtain baseline vital signs before the infusion and again 5, 20, and 60 minutes after beginning the infusion. Fever, chills, and headaches may occur during or shortly after the infusion. If so, diphenhydramine and hydrocortisone should be given and the patient observed for an additional hour. Primary concerns are bleeding, remain alert for increased ecchymosis, petechia, bleeding from other sites, and any changes in mental status. And you want to make sure that they avoid trauma, prevent any skin breakdown. Bleeding precautions, you're going to guaiac stools, avoid rectal temperatures, avoid IM injections, avoid hard toothbrushes, use electric razors, apply pressure to venipuncture sites for 5 minutes, for arterial puncture sites for 10 minutes, and make sure that you include this in patient teaching. What would you expect to find on the lab report? Okay, for platelet counts, hemoglobin, white blood cells, blood smears, please look these up. And I've given you some room here, so maybe you can get this wrote down and help you study for your test some. Disorders of coagulation. Let's talk about your hemophilias. Excuse me just a moment while I find my information that I wanted to give you on this. Okay, hemophilia, it refers to a group of bleeding disorders in which there is a deficiency in one of the factors necessary for coagulation of blood. In about 80% of all cases of hemophilia, the inheritance pattern is demonstrated in the X-linked recessive. The two most common forms of the disorder are factors 8 deficiency, which is your hemophilia A, and your factor 9 deficiency, which is your hemophilia B or Christmas disease. Von Willebrand's disease, or VWD, is another hereditary bleeding disorder characterized by deficiency, abnormalities or absence of proteins called von Willebrand's factor, and a deficiency in factor 8. Von Willebrand's disease affects both males and females. The basic defect in hemoglobin or hemophilia A is with the factor 8, which is produced by the liver and is necessary for the formation of thromboplastin in phase 1 of the blood clotting. Individuals with hemophilia have 2 of 3 factors required for coagulation: vascular influence and platelets. So they may bleed for longer periods, but not at a faster rate. Bleeding into subcutaneous and IM tissue is common. Hemarthrosis, which is bleeding in the joint space, is the most frequent type of internal bleeding. Signs of hemarthrosis are swelling, warmth, redness, pain, and loss of movement. Acquired coagulation disorders are your vitamin K deficiency and your disseminated intravascular coagulation, or DIC. Group A is a bleeding disorder in which there is a deficiency in one of the coagulation factors. The two most common forms of this disorder are hemophilia A classic, which is your factor VIII deficiency, 80% of all your cases, and hemophilia B, which is your Christmas, which is a factor IX deficiency. Both types are hereditary sex-linked recessive disorders which are almost exclusively limited to males, passed from the mothers to the son through the gene on one of the mother's X chromosomes. Diagnosis is usually made by infancy or early childhood on the basis of the history of persistent bleeding. There is a different severity for the deficiencies of factor VIII and factor IX. Mild is 5 to 50% of the factor is present. Moderate is 1 to 5% of the factors is present, and severe is less than 1% of the factors present in that patient's blood. Hemophilia A and B. Your clinical manifestations are easily bruising, prolonged bleeding from wounds, spontaneous hematuria, lower GI bleeds, epistaxis, hemarthrosis in target joints, prolonged bleeding from circumcisions. Your complications can be bone changes, osteoporosis, muscle atrophy, crippling deformities, intracranial bleeding, interstitial obstruction, paralysis, airway obstruction, and secondary infection. Your medical management for hemophilia A will be prevention and treatment of bleeding using your RICE, rest, ice. Okay, you remember your RICE? Replacement of the deficient factors when bleeding does not respond to local treatment. Monoclate or cryoprecipitate factor VIII. You're going to have corticosteroids, DDAVP in mild cases, and recombinant DNA. Amicar should be given prior to any dental work. Medical management for hemophilia B will be factor IX, is Proplex T or fresh frozen plasma, cryoprecipitate, and Amicar will be given prior to dental work for this as well. In the future, you're going to have gene transfer methods for factor VIII and for factor IX because they have been cloned. Nursing consideration and sport guidelines for hemophilia patients. Okay, you need to prevent bleeding while promoting exercise. They need to wear ID bands, avoid IM injections. They need to recognize and control any bleeding, supportive measures, ice, pressure, immobilization. Prevent crippling, so crippling by flexion contractures. So PT might need to be called in, and they need a balanced diet. Support, they will need also genetic counseling, and there is a National Hemophilia Foundation that would provide these patients with excellent support. Sporting guidelines. There are 3 categories for sporting guidelines. Say for those with hemophilia is a category 1, a category 2 are those that are riskier and may be discouraged for some. And then there's category 3, which is risk outweighs the benefit, and they are not recommended. Okay. Von Willebrand's disease is a congenital coagulation disorder that can occur in either sex. It results from a quantitative structure or functional abnormality in the von Willebrand's factor, which serves as an adhesive bridge between platelets. It also serves as a carrier protein for the procoagulant factor 8. Clinical manifestations: it is characterized by prolonged bleeding time and factor 8 deficiency. Clinical manifestations are epistaxis, gingival bleeding, bruising, menuria, GI bleeding, excessive bleeding from after surgery or birth. Which clinical manifestation did I not mention here, but I did in hemophilia? Do you remember? Okay, let's talk about management. Local management: you're going to apply pressure, cold application, tropical hemostatic agents, cryoprecipitate, factor 8 might be needed, DDAVP, or desmopressin. For mild cases, it's only given IV, increases in factor 8 level, and it stimulates the release of the von Willebrand's factor from its storage sites. Acquired coagulation disorders. Let's talk about vitamin K deficiency. Vitamin K is a fat-soluble vitamin. It's a cofactor in the synthesis of clotting factors 2, 7, 9, and 10. It is also essential for the formation of prothrombin. Approximately 50% of acquired vitamin K is obtained from a normal diet, and 50% is produced by intestinal bacteria. So, when would you expect to see a deficit? Clinical manifestations that you will see are prolonged bleeding with minor injuries, easily bruising, mucosal bleeding, epistaxis, emesis, hematuria, melena, petechia, ecchymosis, hepatomegaly, splenomegaly, your prolonged PTs. For medical management, you're going to have oral and parenteral vitamin K administered. You're going to increase your oral intake of vitamin K and transfusions of fresh frozen plasma. Now let's talk about DIC. DIC is characterized by diffuse fibrin disposition in the microvascular, consumption of coagulation factors, and endogenesis, generation of thrombin and plasmin. DIC is a secondary disorder of coagulation that occurs as a complication of a number of pathologic processes such as hypoxia, acidosis, shock, and endothelial damage. It can result from many severe systemic diseases such as congenital heart disease, necrotizing endocarditis, gram-negative bacteriosepsis, rickettsial infection, and some severe viral infections. When the clotting mechanism is triggered in the circulation, thrombin is generated in greater amounts than can be neutralized by the body. Consequently, there is a rapid conversion of fibrinogen to fibrin, and aggregation and destruction of platelets. Second, the fibrolytic mechanism is activated, causing extensive destruction of clotting factors. With a deficiency of clotting factors, the patient is vulnerable to uncontrolled hemorrhage in vital organs. An additional complication is damaged hemolysis of the red blood cells. Okay, your DIC is a complicated and potentially fatal process that is characterized by initially by clotting and secondary by hemorrhage. Bleeding from 3 unrelated sites is a red flag for DIC and should be reported at once. It's almost always fatal, I did not spell that right, and occurs in a response to a primary disease. Your patho, its name refers to its resultant accumulation of microemboli within small blood vessels and throughout the body. The tiny clots interfere with the blood flow and cause peripheral ischemia and organ damage. The result The rapid clot formation depletes the body's supply of platelets, fibrinogen, and clotting factor, leading to uncontrolled bleeding. Clinical manifestations are abnormal bleeding without accompanying history of any serious bleeding disorders. Bleeding in mucous membranes, prolonged PTs and PTTs, decreased platelets and fibrinogen, malaise, weakness, nausea, vomiting, muscle and back and abdominal pain, acrocrinosis, altered sensorium, headache, dyspnea, orthopnea. Medical management, prevention is the key. Essentially, watch that patient that's in with sepsis or septic shock. You want to do generalized supportive care, administer blood and blood products. If caught in the first phase, heparin is administered, and control or eliminate the underlying cause. Nursing management, you're going to monitor the lab studies very closely. You're going to give replacement therapies as ordered. You got to do accurate INOs and weights. Watch for bleeding from any sites. Watch for signs and symptoms of hypovolemic shock. No injections will be given. Protect them from injury. Provide gentle mouth care. Avoid adhesive tapes. Control their pain. Perform passive range of motion and provide them with emotional support. Let's take a breath. I know this is an awful lot of information for you. Okay, now let's go talk about replacement therapies. All right, you need to review the basic blood group compatibilities. You're going to be responsible for this material and covering this topic. Just a short overview. Persons with type A can receive type A and O. Persons with type B can receive B and O, and excuse me, that's A negative and B negative. Persons with type AB negative receive AB, A, B, and O. Persons with type O can only receive type O blood. Now remember your RH factors. Your RH positive can receive positive or negative blood. Your RH negative can only receive negative blood. Now, as you are doing your replacement therapies, you also need to watch for different types of reactions. You have 5 different types of reactions that we have listed here. You have your acute hemolytic reactions. You have allergic reactions. You have pyrogenic reactions or febrile reactions. You have fluid volume overload, and you can have bacterial reactions or contaminated blood products. Okay. Let's see. In your acute hemolytic reactions, they usually occur within the first 5 to 15 minutes. They are the most serious type of reaction. Signs and symptoms will be flushed face, fever, chills, chest pain, dyspnea, headache, feeling of uneasiness, flank and back pain. And when I say feelings of uneasiness, they might express a feeling of impending doom. Okay. Nursing interventions, you want to stop the infusion from running. You want to run normal saline in. And when I say stop the infusion, I mean change out the tubing as well, because you cannot infuse what's in that tubing into your patient. And you want to call the physician immediately. You want to collect urine samples, and you want to send the urine samples and the unused blood back to the lab. And you want to be prepared to give any medications that the doctor will order. In allergic reaction, it will usually occur within 30 minutes. The signs and symptoms will be the hives, the itching, facial edema, wheezing, dyspnea, and anaphylaxis if it's not stopped. Nursing interventions, of course, you're going to stop that infusion immediately, change out your tubing, run in normal saline, notify your doctor, and administer the medications that he has ordered. And you want to follow all of his orders. He will have some other special things that he wants you to do for this patient. Okay? Excuse me just a minute. Alright. In your pyrogenic or febrile reactions, they usually occur within 1 to 1.5 hours. It is a reaction to the white blood cells that are in the blood that did not get cleaned out. Signs and symptoms can be chills, fever, headaches, tachycardia, palpitations, and abdominal pain. Nursing interventions, you're going to stop that transfusion again, and you're going to run in normal saline and clean tubing. You're going to notify that doctor, treat the symptoms, okay, and monitor that patient closely. Those that have a history of multiple transfusions are at the greatest risk for a febrile reaction, so you need to ask your patients before you ever get started if they've ever had transfusions before. Fluid volume overload is a common reaction that you will see in administering blood, especially if you're administering blood to the elderly or someone that has a pre-existing heart condition. Signs and symptoms will be change in breathing pattern. It usually can occur hours into the infusion. Signs and symptoms are changes in breathing pattern, the cyanosis. They'll have headaches, distended neck veins, and you'll hear crackles in their lungs. Nursing interventions, you're going to slow that infusion rate, and you need to notify the doctor and administer any medications that he might order, such as diuretics. Okay, FYI, pain at the insertion site without signs of infiltration or other signs and symptoms is usually related to venous spasms secondary to cold blood. If this is your case, you want to apply warm, moist compress to the site. It usually relieves that spasm. Things to do for transfusions. I've broken this down to before getting blood and after. And when I say getting blood, I mean the nurse going downstairs to get the blood. Okay? Before you go down, you want to check the orders and the lab work. You want to make a card with the ID for your patient on it so you can take that down to the lab with you. You need to ask if they have had any previous transfusions or a history of heart disease. Check the IV site and set up the equipment. You can get your Y tubing out and set it up with your normal saline running in. Okay? Just make sure that you keep the blood port covered up. Listen to the patient's lung sounds for a baseline, and you've got to get a set of baseline vital signs. Okay? Make sure that the patient has been typed and cross-matched within 48 hours, that the order to give the blood has been given. Okay? And you need to ensure that there is an informed consent signed and on that patient's chart. After you've done that, you can go down and get the blood. When you come back up with the blood, what you need to do is look for contamination in that blood. Is there any gas bubbles? Is the blood purplish in color? Are there any obvious clots? You need to literally hold that bag up to the light, squish it around a little bit, and check it out real closely. Begin the infusion within 30 minutes of picking that blood up from the lab. Only use normal saline with the appropriate tubing, and it will be a Y tubing with a filter in it. Okay? You want to make sure that you have another nurse, and it should be an RN, at the bedside to check the blood off with you. You will be checking the blood against the chart and against the patient's bands as well. Okay? You're going to stay with that patient, and I'm speaking of the RN, for the first 15 minutes. Okay? Why do you want to stay with them that first 15 minutes? Is because that is when you have the biggest chance of that hemolytic reaction, is it not? Okay? Administer the blood over the appropriate time frame. The appropriate time frame for administering any blood would be, as far as packed red blood cells would be no greater than 4 hours. And I believe that you'll need to check all of your policies at your hospital, wherever you're working, or your nursing home, to see exactly what time frame they have set up on your vital signs, because some of them are different than others. You want to administer that blood appropriately. Usually, as a general, they say no faster than over a 2-hour period, no slower than a 4-hour period. But like I said, you need to check with your facility to see what their policies and procedures are. Okay, now let's talk about bone marrow transplants, and I'm just talking just a very little bit on this. Like I told you earlier, it is where they're going in to replace the bone marrow, and for the most part you're going to be responsible for this reading of this section, and this material will be gone over with your lecture with Miss Lindsay. You have just a very little bit of material on this in this chapter. Transfusion-related acute lung injury is one of your potentially lethal results from an allogenic blood transfusion. Symptoms can appear within 2 hours and almost always within 6 hours and include dyspnea, tachycardia, fever, frothy sputum, hypertension, followed by hypotension, and pulmonary edema. The etiology is two-hit theory. Okay? Risk factors. Sick patients who are exposed to multiple blood products. At the first signs of respiratory distress, discontinue the transfusion immediately. You need to summon some medical assistance and administer oxygen in order to maintain the patient's oxygen saturation, and you need to notify that blood bank that you've had a transfusion-related acute lung injury. Now, let's talk about your platelet transfusions. You want to give platelets for counts that are below 10,000 per millimeter cubed, or actively bleeding patients. It is pooled from as many as 10 donors. It does not have to have the same blood type. It's usually about 300 milliliters of pooled blood, which 200, they usually pull 200 milliliters if it's a single donor. It needs to be infused immediately over 15 to 30 minutes. It has a special transfusion set with a smaller filter and shorter tubing. Okay, and you do need to have you some baseline vital signs to begin with. Plasma transfusions. ABO compatibility is required for transfusion of plasma products. The infusion bag contains about 20 milliliters. Infusion is rapid, as the patient can tolerate generally over 30 to 60 minutes. It goes through a regular Y tubing set or a straight filter tubing set. Okay. Now let's talk about cryoprecipitate. It's clotting factor 8 and clotting factor 13, or your VWF, and fibrinogen are precipitated from pooled plasma. They're 10 to 15 milliliters in a unit, and it is usually given IV push instead of infused, and is given over 3 minutes. Of course, with something that small, it would be kind of hard to run it in IV, so as a regular drip. So you will be doing it IV push, and it is best to have cryoprecipitate that is ABO compatible with your patient. Now let's talk about white blood cell transfusions. white blood cell transfusions are controversial. They have a potential for a reaction. You transfuse white blood cells. Transfused white blood cells have a short lifespan. They're suspended in 400 milliliters of plasma and infused over 45 to 60 minutes. They require more monitoring and follow the policies of your institutions on these. Autologous blood transfusions are a collection of infusion of patient's own blood. Of course, there are 4 types. Packed red blood cells can be stored up to 40 days. Okay, the blood can be frozen for up to 10 years. Note that circulatory overload and bacterial transfusion reactions can still occur even though it is your own blood, especially the circulatory overload. Okay? Well, that's the end of this one. Like I said before, if you have any questions, just feel free to contact me.